A 41-year-old female patient presents in our office and says, I've got pain on the upper right side and on the lower left side. My tooth is loose on the upper right side. Can you help me? There may be opportunities for us to save them and keep her out of dental implants. How are we going to diagnose it and how are we going to treatment plan it? That's what we're going to discuss today on Practical Treatment Planning. If you take a look at the periodontal probings, you'll see that there's significant periodontal probings throughout the mouth. If we look at tooth number 5, you see there's a class 2 mobility. If you look at tooth number 19, you can see all the bone loss that's present. She's recently lost tooth number 31. Now, what I want you to look at is the occlusion. Take a look as we go through the CT scan, and you'll notice that there is contact on tooth number 3, tooth number 4, and tooth number 5, but there's no contact on number 6, number 7, number 8, number 9, and number 10. So what happens when she goes into protrusive? She's going to touch tooth number 5. What happens when she goes into right lateral? She's going to touch number 5. It's possible she'll even touch number 5 on the balancing side, depending upon where the contact is. The tooth is loose. Let's look also at tooth number 5, because with the class 2 mobility in tooth number 5, and some people might even consider it a class 3, they may very well say, well, let's extract the tooth and put the implant in. And you can see there's plenty of bone for dental implant. But what are the occlusal factors going to be on that implant if teeth numbers 6, 7, 8, 9, 10 are not in contact? Yeah, those teeth, something's going to have to take lateral guidance, and it'll end up being your implant tooth. Do you want your implant tooth to take lateral guidance? We might have to, but boy, I'd rather have natural teeth taking the guidance, wouldn't you? So let's see what the good part is about tooth number 5. Okay, and I'm going to look at a cross-section of number 5, and you'll notice, look at, there's good mesial support. Yes, she's missing palatal support here and buccal support here, but on the mesial, she has great support. Can we build onto that support? Can we use that support? It's the difference between looking at the bad stuff and looking at the good stuff. And the good stuff is that she does have good support on the mesial of tooth number 5. And my goal is to build upon that support. Yes, she's lost a great deal of bone support, and there's significant periodontitis in that tooth, as noted in the chart. And it's likely that where I probe the tooth on the palatal, she's probably lost more bone than that. It just would have hurt to probe. So let's plan on there being more bone loss than that, but still we can build onto the mesial. Now let's look at tooth number 19, which is another tooth that is severely involved, and so we'll look at all the deep defects on that tooth. We can see the pocket depth, and we can see the funneling defect that indicates severe periodontitis on tooth number 19. But now let's look at this. Let's look at the mesial aspect of tooth number 19, or the mesial root of tooth number 19. Take a look. There's good bone support there. I don't want to sacrifice that bone support. Do we need to do an implant there? Probably not. We've got to get the infection under control. Maybe get the occlusal portion of it in control. But just because we have a deep distal defect, we don't necessarily condemn the tooth, because we've got all that good mesial bone to work with. The number 5 has 2 problems. Number 1, it has all that bone loss, and it is in parafunction. No matter where she touches, she's touching that tooth. With a periodontal disease, certainly we need to clean the root up, and we're going to. What can we do to help the parafunction? What we can do to help the parafunction is to put number 6 into contact. How are you going to do that? How about putting a lingual contact on tooth number 6? And so now number 6 provides canine guidance where it wasn't before. Simple composite. No drilling at all. Just add composite to the lingual aspect of tooth number 6 so it's in contact with tooth number 27. Will that help tooth number 5? Well, yeah, it probably will. Let's look at all the rest of the x-rays. You can see in the full mouth series, the patient has severe periodontitis, so it would be considered at least, she's not missing any teeth yet, so it becomes a stage 3. And grade B, I'm just going to say it's slowly moving, although it may be quickly moving. It may be a grade C. I can't tell. Call it either one. She has significant periodontitis. We have to address it, but we have to address it both from a bacterial standpoint and from an occlusal standpoint. So what's the sequence that we're going to take? Number one, I want an oral DNA test. I want to find out what bacteria is growing there. And I do want an antibiotic in place because at the age of 41, I'm going to classify this as an aggressive periodontitis. We'll determine that when we get the results of the oral DNA test back, which will be in about a week or 10 days. Number two, I want to take the stress off of tooth number 5. So I want to do an occlusal adjustment on tooth number 5. But what else do I want to do? I want to place a lingual composite on tooth number 6. So number 6 and number 27 are now in contact. That'll do a couple of things. Number one, it'll allow number 6 and 27 to do a lot of work, and they haven't lost very much of any bone at all, and it'll take the stress off of tooth number 5. So it won't just be the occlusal adjustment, but now in lateral contact and even in centric contact, tooth number 6 will be in touch with tooth number 27. It's going to take a lot of stress off of tooth number 5. Number 3, I'm going to ask the patient to order a nightguard. I happen to use this particular nightguard. I like the anterior contact. The posterior teeth are not in contact. It's easy for the patient to wear, and it's cheap. The patient doesn't have to spend a lot of money for this. The patient can just order this online, and for about $60, has something that will at least exclude providing anterior function and not allowing her to touch the teeth at night. Next will be periodontal endoscopy. Yes, we're going to go into those areas and clean every one of those roots. We will see microislands of calculus after we get rid of the big sheets of calculus, which are likely there. And the microislands of calculus can be identified with the scope. We can see it. And with some of the newer materials, such as EDTA, we can get those root surfaces really, really clean. So we're using EDTA in the form of Pref Gel. Pref Gel is made by the Straumann Company. In order to be able to take care of that, the Pref Gel is placed on the calculus to begin with. We leave it in place for only 1 minute. Then we'll rinse it out. Then we'll scale root planing. We'll re-inspect using the scope. We're doing our scaling and root planing under the scope because the scope magnifies the root surface by at least 40 times. There's one scope that's made that magnifies the root surface by 100 times. Our whole goal is to get the root surface pristine. Get that root surface totally clean. We can't do that with blind scaling and root planing. Blind scaling and root planing will only take us 4 millimeters below the gum line. That's as far as we can get with a good hygienist. But with a scope, with inspection, then we have the opportunity of seeing the root surface deeper. We can see where the calculus is and get that out. And with the addition of the EDTA or the Pref Gel, we can be even more efficient at removing all of that subgingival calculus. We'll then wait 6 weeks and we'll reevaluate. At the time of reevaluation, we'll do the following. First, we'll do an oral DNA test before we polish the teeth. Second, we'll polish the teeth. Third, we'll probe and we'll reevaluate with the doctor, and we'll see where she is and whether we go on maintenance or whether there's further treatment that's necessary. Finally, I want more posterior support on the right side. Now, ordinarily, I won't put in second molar implants, but here there's no anterior guidance. 6, 7, 8, 9, and 10 are not in contact. I want tooth number 31 back in contact with tooth number 2 in order to be able to relieve the stresses, particularly on tooth number 5, and by adding that additional functional contact, that will help tooth number 5. And then it's a matter of monitoring the healing. Notice I'm not in a hurry to extract tooth number 5. I'm not. Do I advise the patient that she may lose tooth number 5? Yes, of course. But what we're doing is reversing every one of the stresses: occlusal stress, bacterial stress, and we're adding occlusion to areas that have not been occlusion her entire lifetime. 6, 7, 8, 9, and 10 will be in contact with the nightguard at night, and number 6 will be in contact with the composite on the lingual. By doing that, we then have the opportunity of monitoring healing and saving her teeth and giving her the opportunity to function this way without any implants, without any prosthetic appliances, hopefully for much longer. We know the dental implants are more susceptible to peri-implantitis when a patient has periodontitis, and she has periodontitis. What we're doing then is delaying the placement of the dental implant. hopefully forever. But even if she gets another 5 years, 10 years, 20 years out of that, we don't know where the technology is going to be in 5, 10, or 20 years, do we? And we have the opportunity, therefore, of maintaining the teeth as is, delaying implant placement, allowing her to function, allowing her to smile, and hopefully keeping out of the implant arena and the prosthetic arena for much longer. The only place we're going to put in that prosthetic appliance by an implant is in tooth number 31. Okay? Please put your comments in the comments section, and I thank you for joining us. We'll see you again soon.